Hey everyone, welcome back to another episode of Rad Path Rounds. I am Ryan Appleby, a veterinary radiologist.
And I'm Kate Baker, a veterinary clinical pathologist.
It's great to see you again, Kate.
We've
got a really interesting case for everybody today. This is going to be a fun one with a little bit of controversy associated with it. Ooh. All right, so let's jump right on in. So today's case is a 10-year-old female spayed Schnauzer cross who is straining to urinate. As part of our diagnostic testing, we want to take radiographs to evaluate for a cause of why this patient might be straining to urinate. So on the left-hand side of our screen, we've got our ventrodorsal projection. That's this guy here. And then we've got our left lateral projection here. Now, in most instances, we want to take 3-view abdominal radiographs. And for conciseness, I've just shown you 2 of those images here today. And that's just to make it easy for us to present. The major finding in this patient is that the bladder is massive. This is one of the biggest distended bladders I've seen in a long time. It's extending all the way to the mid-abdomen. So this rounded soft tissue opacity structure here in the caudal abdomen, this is all urinary bladder, and that is markedly distended. So of course that fits with our patient straining to urinate. But the question is why? Why is this patient struggling to get the urine out? Why is it all being retained? And so the things that I'm looking for in these instances, are there any uroliths? So are there stones in this bladder or maybe stuck in the urethra? Stones that are stuck in the urethra, of course, are going to be a bigger problem in male dogs compared to female dogs because of the diameter of that urethra. But we definitely want to look for that here. And I do not see any. So if I kind of trace along the margin from the bladder neck, caudally along the path of the urethra, I don't see anything that indicates there's any uroliths present. It's uniform soft tissue, this bladder. There's no evidence of any radio opacity abnormalities. And I'm not seeing anything else in this region. Is there any like external compressive mass or anything like that? So unfortunately here, I've just got a really distended bladder and no radiographic reason why this patient would be straining. So marked urinary bladder distension, no evidence of urolithiasis. So what are our next steps going to be? Well, we're going to need some more diagnostics. We're going to need an ultrasound. And then hopefully, if we can get some urine from this patient, a urinalysis and culture. So when we went to ultrasound this patient, what we found was an abnormality at the level of the bladder neck. So this is a longitudinal image of the ultrasound, meaning that we are in long access to the bladder itself at the level of the bladder neck. This area here is the lumen of the bladder, which contains this echogenic material. So instead of it being completely black, as we would expect for most normal urine, we've got this more white speckling of it. So this is echogenic material within the urine. And then this whole region here is the bladder wall. And at the level of the bladder neck, this dorsally positioned larger region, this mass, is present. And so this is evidence of a mass in the urinary bladder wall. When I look at this, what I'm seeing is that there's no wall layering associated with this. So normally we should be able to see kind of a nice dual layered bladder wall. And we're not seeing that here. It's very heterogeneous. And there are these regions of hyperechogenicity along the margins of it, which could be an indication of some mineralization in this mass. So we've got this large mass of the bladder neck, kind of in the region of the trigone. And we're going to need to figure out what this is. And that's where some of the controversy comes in. So hypoechoic mass of the bladder trigone, loss of wall layering, expansion of the wall, hyperechoic foci and mineralization. We've got that echogenic urine, so it's not that normal anechoic black. And my differentials for this is neoplasia. That's going to be number 1, first and foremost, something like a urothelial cell carcinoma, or unlikely to be something granulomatous like granulomatous cystitis, not as common of a distribution and not as common of a disease. So we need to sample this. We got to figure out how to get a sample of this. And we can also do urinalysis, BRAF testing, and staging of our patient whenever we see these.
Yeah, so that's all super interesting. And that mass surely looks gnarly there. I can even see it, and I don't really know what I'm looking at anymore with ultrasound, but it's definitely there, right? And I've actually seen some cases where, as I know you have, that it's amazing how that cystitis can look really mass-like. So even though we have neoplasia at the top of the list, like you said, we have to get more information to make that definitive diagnosis. And so the question is, what step do we take next? And traditionally, FNA of bladder masses has been a viable option. In the past, we think, okay, stick a needle in it, see if we can get a diagnosis that way, and specifically stick a needle ultrasound guided through the abdomen percutaneously. In my experience as a pathologist, this is a nice way of sampling just simply as a pathologist, because I usually get a really cellular sample that way. Versus if you're taking a more indirect route and you're doing urinary catheterization, like traumatic catheter, or just collecting urine free catch and trying to spin it down. That said, this is where the controversy is, because I'm sure some of you are thinking, no, you can't do that. And you're right. The problem with that direct aspiration of the mass is that we now know that those tumor cells can actually seed along the needle track. And this is a huge problem when it happens. And it's not unique only to UCCs, so urothelial cell carcinoma, which also is known as transitional cell carcinoma. That's probably the term more people are used to, but terminology change here. So we'll talk about it as urothelial carcinoma, but TCC is the same thing. So going back to that, that's not the only tumor that can do this, but it's the one that we think most commonly potentially doing this. And that can be a huge problem if it happens. Now, does it happen super often? I've looked into this in the literature. I haven't been able to find a direct percentage. There's some controversy about how often it happens. Some people say I see it happen often, the seeding, that is. Some people say it's rare, and so you have to get a sample. So you kind of just deal with the potential consequences. The thing is that now we have BRAF testing, which you just mentioned, which is an excellent molecular test for detecting this type of carcinoma, urothelial carcinoma. It's an excellent test. And so with the onset of that, or the availability of that test, there's really not a time that I'm often going to recommend direct aspiration of the mass. Traumatic catheterization is still an option. It's much less likely to do seeding down the urethra, but it still can. So you have to be aware of that, but it's less likely. So you've got a couple of different options, but definitely if you're not aware of the BRAF test, keep that in mind. The cytology I'm going to show you is representative of the disease that this patient from the imaging had. It's not the exact same patient, but with this particular sample, it was collected by direct aspiration of the mass. So they used ultrasound guidance. It's a little bit of an older case. So this was before the availability of BRAF. But this is just excellent because it's going to show you what this looks like on a cellular level. And again, if you're looking at free catch urine or traumatic catheterization, you'd look for these types of signs that it might be cancer. So with all that said, here's the cytology. So this cytology is really cellular, and bladder walls, like if you're directly aspirating a bladder wall, again, it really just shouldn't have a high cellularity. Normally, if you're trying to hit it, bladder walls are really tiny, thin, you're really not going to be able to hit them. But if they've got a mass type lesion there, you might get good cellularity. And so that's what we're seeing here, very cellular sample. And what are these cells? Well, the first thing we ask ourselves is, are they inflammatory or do they look neoplastic? And in this case, these are not inflammatory cells. So I'm already thinking, okay, cystitis is, with cystitis, we expect some inflammatory cells. We can see epithelial cells with cystitis because of that bladder wall proliferation. It's non-neoplastic, but it's proliferating. But that's not the case here. What we are seeing is just a big population of atypical epithelial cells. These are all stuck together in clusters like we expect epithelial cells to be. And then the next step in our thought process is, okay, now I've identified them as epithelial, but do they exhibit criteria of malignancy to support that they're carcinoma? This can be a little bit tricky on cytology, especially with bladder, because for the reasons I just mentioned. If you have cystitis and you have hyperplasia of the bladder wall because of inflammation and irritation, it can look a little bit weird on cytology. So you have to be a little careful. This is where, incorporating a cytologist, a pathologist into your practice and sending samples to them can be really helpful, because we're able to say, nope, this is way beyond what I would expect for hyperplasia as far as atypia goes. So that's what's happening here. This population has a ton of criteria of malignancy. These cells are really large in general. We've got anisocytosis, so different size cells. We've got anisokaryosis, different size nuclei. We've got prominent nucleoli, which we'll see a little bit better in the next slide. We've got multiple criteria of malignancy to really support that this is a malignant population. You can also, even if you have cytology that really says, this looks like carcinoma, you can still do the BRAF test, one, to confirm, just to make sure, because sometimes we like that extra confirmation. And two, it can help guide treatment, because you can actually do BRAF testing serially to guide your treatment and see if the tumor cells are, responding to treatment. So getting a little bit closer, I just want to show you the coolest part of these cells. All right. This is so pretty. I'm telling you, this is so weird, but it's really cool. So here we've got a couple of tumor cells, and you might have noticed this in the last picture, but it was a little farther back. These cells contain these big cytoplasmic inclusions, and they're this magenta pink color. This will be what it looks like on DiffQuick as well. And these are actually, they're not specific for UCC, but we see them a lot with UCC. And what it is it's this polysaccharide protein material that the cell is just making, and it's making it inappropriately. They actually have a fancy little name called Melamed-Walensky bodies, just for your bar trivia, in case that ever gets asked at bar trivia, But what we're seeing here, just wrapping up the cytology, is this markedly atypical population of epithelial cells. They contain that intracytoplasmic material that when I see that, I'm like, oh, that's so inappropriate for these cells to be making. I just don't typically expect a non-neoplastic population of bladder cells to be making that. So my cytologic diagnosis in this case is urothelial cell carcinoma.
Wow. Those inclusion bodies are something to be.
Aren't they
That
neat?
is so impressive. So cool. I loved a couple things you said there. The first being about this controversy over the fine needle aspirates, getting an answer, BRAF testing. I think you and I are both on the same page here. At this point in time, because of the testing available to us, we should be doing everything in our power as veterinarians not to direct sample these. There is a risk associated with that needle track seeding. We have these other tests available. Let's do what we can in our power to not do that. And in the very rare exceptional circumstance where we need an answer and we, for whatever other reason, can't be doing those other tests, maybe then we're seeking out some of that direct aspiration.
Yeah, like if the client can't afford the BRAF test because it is a little pricey, or if you're in a location geographically that doesn't offer the BRAF test, we understand you can't always do the very top of the line thing. So sometimes it's necessary, but you just have to warn the owners about that potential.
Yes, exactly. That client communication, so important. And that other thing that I love what you said is incorporating that cytologist into your practice. You and I are both here because we are passionate about empowering veterinarians to improve their radiology and their cytology skills. But still knowing when to kind of send out those tests is going to be super important and is going to help level up some of that practice. So I love that idea as well. So, both of those things combined are super cool. And this is a great case example of that. So, just summarizing urothelial carcinoma, it commonly presents with lower urinary tract signs such as hematuria, stranguria, and plaquuria. And, what's interesting about these cases is sometimes we see a little bit of temporary relief with antibiotics. And so you might try a course of antibiotics because you might even get a positive culture or some evidence of cystitis, a bacterial cystitis, on your urinalysis because there are secondary infections here. So we do sometimes see some temporary relief, but these are going to be persistent over time. And these can also commonly metastasize. So it's super important to do our staging, thoracic radiographs, thinking about an entire abdominal ultrasound as well. And for whatever reason, the Scottish Terrier breed is one that is overrepresentative. You know, this study that I have up in the corner here from the Veterinary Journal, they talk about a 21 times more likelihood in Scottish Terriers. That is a big number. So certainly if you're seeing a Scottish Terrier presenting with these clinical signs, that's something you've got to be thinking about. And therapy for these are going to be chemotherapy, COX inhibitors, and depending on the location, we can consider surgery. So in the case we showed you, not an option because of the trigone or bladder neck location, but if it's at the apex of the bladder, we might be able to do surgery to help that. And prognosis for these patients is actually quite good, sometimes over a year of survival. And that is pretty cool. And, you know, this is a nice opportunity to talk about learning a little bit more about urinalysis. This is actually the first course that I took on Veterinary Cytology Schoolhouse. Kate, tell us about the urine course that you have.
Yeah, if you guys are interested in learning more about urinalysis and specifically about how to interpret transitional epithelial cells, because I know when you're looking at those on those free catch urines, it can be like, is this cancer? Is this not? You know, what is it? I encourage you to check out my urine course. It's a completely free course. It's delivered through email. And so you'll get a 5-day series of emails where you get a little video, very short, easily digestible, and a little supplemental material for that. And you'll learn a lot, hopefully, in that 5 days about urine and kind of up your confidence when you're looking at those samples.
I love it. So good. It was such a great course. I obviously don't do a ton of urinalysis in my practice, but I really enjoyed it. So I hope everyone checks it out. Well, this has been a lot of fun as always. And I guess, unfortunately, it's time to say goodbye until next time.
Yeah, we'll see you guys next time. Thanks for watching.
Bye.